I'll start with a few, and then we can circle around
That'll,
if there's more time. I see Brent is on here too. Hey
yeah.
Brent, I don't know if Art is watching in the background, but hopefully he is for this case. This is
Uh, Not yet, but
is he going to be in the room? I'll save this one then.
he may be later, but he's not
Okay.
yet.
I'll start with this one then in hopes that he comes in. This is a nice radiograph that I saw recently, and this is kind of the endpoint of this process that you see here. And I think it's obviously there's some subtle findings here, and I think that the more you look, the more you see. First of all, you notice a discrepancy in the volume of the left versus the right hemithorax, and the left hemithorax looks a little bit more lucid as well. The vessels are a little bit more spaced apart. And then you can see that there is this kind of vague band of opacity here medially. And you can see on the lateral view that you have this abnormal line as well. So it's pointing towards a subtle left upper lobe atelectasis case. And what's really interesting about this case, because it doesn't really show up that well on the radiograph unless you really window down, but you can see that there are these little endobronchial valves. And so then if I go back to the original post-placement radiograph, you can see that, let's see, if I can get the PA and the lateral views up side by side. Um, yeah, you can see this is kind of the intended consequence of placing endobronchial valves is here we started to develop a little bit of collapse of the left upper lobe, and this patient, of course, has underlying emphysema. So this is a minimally invasive volume reduction surgery, as you can see from their preoperative CT, how severe their emphysema is. So they chose to do this volume reduction in the left upper lobe, and apparently the patient is symptomatically better. But I thought this was just a nice radiograph because the valves are really hidden on this radiograph, but it's a nice example of complete left upper lobe atelectasis as a result. And unfortunately, I don't have a more recent CT to show the correlate, but I think the left upper lobe is just completely pancaked along the mediastinal pleural surface in this case with these valves. And you can see that they've placed, I think, 3 different valves in this patient into different segmental bronchi, including the lingula here.
Hey,
So we're
Travis,
doing a few of them. Yes.
if you look at the airways on that CT, it looks like it's an expiratory airway. You might wonder if there's some malacia in there. They're pretty
Yeah.
flat, and wonder if that's contributing.
That's a good point. I bet it is.
Just adds a little bit more to it.
Yeah, probably to their overall symptoms, you're saying?
Yeah,
Their overall clinical
not a lot of
picture?
reserve for that airway either. So maybe that's
Yeah.
contributing to the collapse.
Yeah, I'm sure that this would be greater than 75 or 80% cross-sectional area, so it would meet most definitions of excessive
Especially
dynamic airway
the left
collapse.
main bronchus looks pretty darn, and the right main look pretty flat.
Yeah. Yeah. Yeah, and even look here at the left lower lobe bronchus. Yeah, that is pretty impressive. I hadn't been paying that much attention to that when I was reviewing this. Let's see. This next one, I've shown cases of uh, similar findings, different side, but I always like cases like this, and I think it illustrates an important point. So this is a patient who, at this time, this was in 2015, outside radiograph has what looks to be a necrotizing left lower lobe pneumonia, and you have this area of necrosis, which looks like it's in the lung and surrounded by consolidation. And so this was called necrotic pneumonia, maybe due to aspiration. And they failed to pick up on or failed to realize, actually, I believe the clinicians knew at this point, but this lady had gastric bypass, which had been complicated by an abscess in her left upper quadrant. You can see the breakdown of the staples and this fluid collection that seems to extend outside of the confines of the excluded stomach. And the patient came back. This is still at the outside hospital, and you can see so you can see on the more recent study, which is over here, that they now have this enlarging area of consolidation in the left lower lobe. And at this point, actually, the outside radiologist, when I was looking at the report, raised the question, could there be a cancer here? But of course, whenever you have persistent abnormalities or abnormalities in the lower lobes that abut the diaphragm, if you always have to look on the other side of the diaphragm, and vice versa. If you have something going on in the abdomen, look in the lung or the pleural space and see if there's any sort of communication. And on this study, you can actually see that there's this tract of air that goes straight towards this area, and I think it's nicely shown on the coronal views as well on the more current study, that you can even almost connect the dots completely into this area. So this was not cancer, not pneumonia from aspiration. Rather, this was now confirmed gastrobronchial fistula, related to this patient's surgery. And the surgery had actually originally been, I think, in 2011, or it was several years ago, and she had multiple intra-abdominal abscesses, and this had only developed over the last year. But they finally resected her left lower lobe within the past few months. So I thought this was a nice case. Just again, I know I've shown bronchobiliary fistulae on the right, where you have abscesses that make their way into the pleural space and end up communicating with the lung. But again, I think this is a good example of this, and always something to think about when you have lower lobe pleural or parenchymal processes. And let's see. Another one, just a good example of this finding. I'm going to go, let's see, figure out which study is which. This was interesting just because we have the pre-incident here. This is a patient that has you can see, has had a mechanical prosthetic aortic valve and a root and ascending repair. You can see the distal anastomosis with the felt pledgets here. So it's kind of a version of a Bentall. I don't know what the exact valved conduit is that they used in this case. But this was done originally, you can see the guy's 55 years old. This was done for endocarditis at one point, and this was in March. The surgery had been done elsewhere, and then he came back in June with fever that was new. And having the previous study was helpful, because now you can see clearly that there is this new rim-enhancing fluid collection surrounding the aorta, and it goes from the graft, from the root all the way up the graft towards the distal anastomosis of the graft. And you can see there's a little bit of inflammation of the fat in the mediastinum as well. So the surgeon was kind of in denial, I think, and so as you can tell by the fact that they didn't believe this was necessarily infected, as they just did, instead of, while the patient was on antibiotics, just continued to get serial imaging follow-up because they weren't sure exactly what else to do. But you can see the natural history of this. You still see this perigraft fluid collection, which he's bacteremic at this time again, and with growing Staph aureus out of his blood. And they still didn't really believe that this could be infected, and then ended up with a gated study a few days later, just to show how the extent of all the inflammation. We were having a hard time convincing them until he came back in when I was working a few weeks ago on a weekend, and now you can see that there's actual there's active extravasation of contrast into this, and it looked like the epicenter was at the distal anastomosis. So we thought this was probably an infected graft that was complicated by a dehiscence at the distal anastomosis, which is exactly what this turned out to be. They finally took him to surgery after this, and you can see on the delayed a little bit more contrast leaking into there. With all the adhesions and all the inflammation, he's not at high risk of rupture in the acute setting, but of course this is a foreign body that just stays infected, and so they finally operated on this. So a good example of just the evolution of a perigraft abscess. And I think it's important, as I said, to have to see the original study, as occasionally you'll get a little bit of fluid in the post-operative state just surrounding it in an otherwise asymptomatic person if they have hemothorax or just a little bit of blood that doesn't resolve, or they may get just a benign inflammatory reaction to the graft. But it should certainly never increase like this afterwards. And usually, if there is a little bit of fluid in the perioperative period, it should either stabilize or go away, not the latter, or not the opposite, which is increase like this. And finally, I'm going to go back to this case now, Brent. Uh, so this is one that is kind of it's a very interesting case. This was a patient at the VA, and you can see this was an abdomen and pelvis CT from 2015, and this was just a corner shot where they saw this about 1.6 centimeter pedunculated thing arising in the region of the interatrial septum, presumably near the fossa ovalis. We don't ever get up that high, and you can see it's pretty low attenuation. So based on this, they thought it's probably going to be myxoma, maybe a thrombus. And they put the patient on anticoagulation, and I'll show you they did a follow-up MR about a month later. You can see April 22nd. And you'll see here that on the four-chamber cines, you really don't see anything in this area. You can maybe hallucinate, I don't know, a little tiny residual lesion here. Now let me find the short axis and I'll show you. You can see it a little, you can still see a finding on the short axis here, but notice how it looks much smaller and measures less than a centimeter, at least visually, it appears smaller here. And it wasn't visible much on the other sequences, like the black blood sequence. And so for that reason, they thought it was probably the person who interpreted the study, maybe you can see there's a little bit there, thought this was probably going to be a thrombus. But then fast forward to this MR, they did a repeat MR 6 months later to see if it had gone away. And now you'll see, if I can find a good, let's see. Now you'll see on this one that it is now readily apparent and looks to be almost identical size to the original study, which was somewhat confusing because she was on anticoagulation because they thought this was probably a thrombus, and you would think based on the behavior that it probably was too. You can see on the black blood images it's easily visible at this time. And so the question was, is this thrombus that just got worse, or could it be a myxoma that is just not visible on this study? Myxomas can be iso-intense, especially on these steady-state pre-procession images. We couldn't really explain why you wouldn't see the rest of it on or see it on the other sequences as well. But to make a long story short, they recently took her to surgery and took this out, and it was a myxoma, and it was about 1.6 centimeters. So, and there was no thrombus associated with it, which is really interesting. I don't know, I thought maybe there was going to be a little bit of thrombus associated with this, but like I said, it's been reported that, and it's well known that myxomas can be difficult to see on sequences like SSFP cines. But I'm just curious if anybody else has any thoughts about this, because certainly a myxoma shouldn't shrink.
What was the time difference there? Like, was there a thrombus, that had just responded, or what had just shrunk a little bit?
Well, that's a good question. The original study was, as you can see, was March of 2015. This MR was done a month and a half later in 2015, this original MR, and then the follow-up MR was done 7 months after that in November of 2015. And she'd been on anticoagulation the whole time. And so they had done this repeat MR, thinking this was probably thrombus because it had been shrinking, seeing if it was completely resolved, if they could take her off of the anticoagulation. And of course, it hadn't resolved, and so they decided to take her to surgery, because I think that's when I was thinking it was probably a myxoma, and that maybe it was just not well seen on this prior study. But
what was your slice thickness?
the slice thickness looks like 8 millimeters on this study, and then
What was the
5
gap?
millimeters on this one.
Was there a gap?
I don't, that's a good question, Seth. I don't know. I mean, I think that
I'll just tell you, we had a case the other day of left apical, looking for a left clot in the left apex post-MI, and just on our lokes, I saw it on the lokes, and literally every single sequence, the tech jumped over it, literally just jumped over it. And it was about this size too.
yeah.
And, I'm like, God, I see it on that loke, and I questioned it, and we got a CT, and it was clear as day on the CT, about a big centimeter and a half thrombus sitting So I don't know if you're just jumping over it and the tech is just because I, I'm always a little, I believe it was there and it was just wasn't imaged. The tech just probably popped and caught the very top and very bottom of it on a lot of the sequences. That would be my guess.
Yeah, yeah, and I think in addition to it, probably, on at least on the cines, that it's just, hard to see. Let's see if I can find, let's see using the localizers if we can see how much of a gap there is. Yeah, it doesn't look like there, yeah, it does look like there may be a little bit of a gap. You
And
can
it's
see
surprising
from,
because if you catch like the bottom of the one and bottom of the other, and they
yeah,
start using that as their reference, and it's really unbelievable some of the things I've seen. Just like it's there till you see it on one sequence,
right.
but you don't see it on the others, and it's always it makes me nervous. 'Cause-
Well, right, and exactly, and that's why ultimately, we said, this needs to come out because I don't know if it ever shrank. It probably didn't. Probably was we just didn't see it. So, but Seth, I'm glad you're on there to see that too because this was, somewhat perplexing case. But yeah, it just bothered me.
yeah,
All right, Jeff, I'll stop there.
Okay, thanks. Seth, you want to go next?
sure.
All right.
So I will start from, I guess, the least interesting case first. This is just, I've never seen this happen before. So this was a woman who came in um, with a anterior mediastinal lesion. It looks relatively dense, and it measures whatever, about 5.5 centimeters in length. Obviously, very concerning for a thymic tumor, thymic epithelial tumor. So she didn't want anything done. She comes back a few months later, and it's dramatically decreased in size. And I did all this volumetric stuff on it. The attenuation wasn't changed. Because I had not seen this, I mapped this out. It was after we knew what it turned out to be. It was decreased in size. She actually had a few more CTs between these dates and the final date in December, which showed it was unchanged. And then she came in December, and we were still concerned, but the question of something else, just benign, was raised. And then this is a few months later, and it's an awful, ugly mass, and this was actually a thymic carcinoma. And the reason I had actually started looking at it was because she had lung mets, and as we know, most thymic tumors don't metastasize to lungs, but thymic carcinomas do. So I assumed that there was probably some hemorrhage or something in this lesion initially that caused it to grow and then shrink, but I did all this, measuring attenuation and stuff, and it was unchanged in attenuation. I have seen some tumors mildly contract. I've never seen a thymic one do it. I don't know if anyone else has seen that, but it's just it is what it is. It's a thymic carcinoma that, for some reason, maybe it did hemorrhage and we just didn't see it. That got dramatically decreased in size, but then it was what it was. This
That's a
is
little worrisome because
yeah.
if I saw that thing shrink, I would have thought maybe it was a hemorrhagic thymic
This.
cyst that was
Well, that's
evolving.
what and that's what was raised, and we said get an MR, and look at this thing. Maybe it was just a cyst that hemorrhaged, a thymic cyst that hemorrhaged. I mean, we were pretty concerned off the bat, and said it should come out, and then the patient's like, I don't want anything done, and then it decreased. We said maybe it was a cyst, get an MRI, and it was a lot of it was patient factors. She didn't follow up, and there was a delay. But anyways, it turned out to be a thymic carcinoma.
What was the original study done for? Did she have pain
I
or
think
some?
she was no, not at all. It was an incidental finding on a radiograph. One of these. Who knows why she got a radiograph? She had a cough, got a chest X-ray. It was picked up on the chest X-ray. She went to CT, and then that was the initiation. It wasn't a symptomatic. She didn't have any syndrome associated with thymic carcinoma. She didn't have any endocrine issues. It was just like we see so many random X-rays for who knows what. The next case is kind of random because, you know, I showed that double the hemiazygous continuation case going into the left SVC, and then sure enough, I was at our VA the other day, and unfortunately it's non-contrast, but literally this patient has the different but same thing. She has also the hemiazygous coming down and also drains into a left SVC. So there's a left SVC, and that's where it drains into. She also has a right SVC, but she has a lot of other stuff. This person does have an azygos. The other patient I showed did not have an azygos. This person was relatively asymptomatic. She does have pulmonary hypertension for potentially something going on in the heart. But anyways, long story short, we look at so there's normal levocardia in the chest, but if you go in the belly, you actually see situs inversus with polysplenia. And again, she had never presented with anything else. She actually has bilateral left-sided bronchial anatomy. So there's, you know, both hip arterial kind of bronchi, and she does have a little residual right middle lobe, not kind of a normal right middle lobe, but a residual kind of right middle lobe. But anyways, I just thought it was interesting that saw two of these hemiazygous going into left SVC within a few weeks of one another. And so this is a case of bilateral left-sidedness, but has the situs inversus and the polysplenia. And she's never had any, and usually associated with complex congenital heart disease. But looking up her history, she's been asymptomatic till now. But I recommend they get some sort of cardiac study, at least an echo, to see what was going on, because she did have some pulmonary hypertension, supposedly. Okay, and then this was, oh yeah, this was a neat case. My chest CT, oh, my chest CT didn't come over. Oh, that stinks. So this is a woman we were doing, oh, that really kind of stinks, doing a follow-up study on, and she had these sclerotic bony lesions, which I would have liked to show you, but for some reason the case didn't come across. So she has these scattered sclerotic bony lesions that were very weird looking in the sternum and some of the ribs, and this was an older study from about 4 or 5 years later, and you can see there's this big multiloculated cystic collection in the left upper quadrant, left lower quadrant, and this very strange bone finding with this, which is better seen on the MRI. And you can see that the spine is, or I don't know if it was L4, L5, is filled with a similar multiloculated cystic structure as you see in the left abdomen here. And the bony findings in the chest were similar. She actually underwent, because this lymphangioma in the bone was so large, she actually had to have that surgically corrected. The other ones in the sternum and elsewhere were smaller. So they resected the lymphangioma in the abdomen and pelvis. They they did surgery on the lymphangioma in the bone there. And so this was another case of Gorham's, which is congenital lymphatic malformations and associated bony anomalies. And the bony anomalies are associated with, basically lymphangiomas going through the bones. So I had shown a case a couple of years ago, and this is a nice case of it as well. And I'll include the chest CT findings on the other study when I download it, that has all the bony findings in the chest as well.
So what's going on with her left ventricle? It looks very dilated there.
Yeah, I don't know. I mean, it was that. I mean, tell you the truth, it doesn't really bother me too much here. If we take it into more of a 4-chamber view, she kind of has a very downward sloped heart, just the way she's kind of a thin woman. So if you look at it on a more 4-chamber view, it's not gated, but it looks, I think, better in size on here. And on the follow-up studies that were contrast, it didn't look bad, and her lungs were normal. She didn't have any evidence of kind of septal thickening or anything in the lungs on the newer old study. So those are my cases.
All right, thank you. Brent, do you have cases?
Yes, I have some cases.
All right, go ahead.
Can you see my?
Yeah, we see your screen.
Okay. Okay. Here's a patient who, in the acute setting here, came in with a pneumothorax on the right, and you can already see that there's diffuse abnormality within the upper lobes. You can see this what I like to think of as bronchial.
Brent, we
Yeah.
don't see your
Yeah.
database window. You have to on the Osirix where it's under the show, but on the GoToMeeting panel where it says show. You have to select the right. There you go.
Okay. See now?
Now we see it.
Okay, sorry about that. In the acute setting, this patient came in with a right pneumothorax, as you can see. In the upper lobes, you can see this relatively diffuse abnormality with architectural distortion. You can see that there is peribronchiovascular sort of retraction with a traction bronchiectasis with, sort of a clumping together of the upper lobe bronchi here. You can also see that there is some nodularity here along the septa. You can see that there is a little bit of thickening here at the lung apices along the pleura and along the subpleural parenchyma. And as you go down, those findings become less significant. So here, I think originally I was thinking of things like sarcoidosis. We typically see this in sarcoidosis. Also, chronic HP, I haven't seen such dramatic bronchial retraction like this in that condition, but that would also be obviously in the differential. But the key really is the thickening along the pleura and the subpleural parenchyma, and this turned out to be a nice case of pleural parenchymal fibroelastosis. So I just thought that was a nice demonstration of pleural parenchymal fibroelastosis. And I heard something really interesting at the last STR, someone actually, I can't remember the speaker, was talking about this disease and saying that their pathologist actually, or actually maybe that was on this conference actually, was saying that her pathologist actually when resected lung, they view resected lung from older patients who have sort of this scarring at the lung apices. It's very similar pathologically to what they see in pleural parenchymal fibroelastosis. So I think that's interesting. She was claiming that it's kind of a continuum that they see from kind of normal apical scarring to this more fulminant disease state. So anyway, just a nice case there.
And Brent, did this patient have any underlying risk factors, or is this a familial case?
I don't think this is a. I need to get back to you on that one. I don't think so. No. So I don't know that this patient had any risk factors, and I don't know that this is a familial case, but I'll have to get back to you on that.
And it's not ankylosing spondylitis or anything. The spine was okay?
Yeah, not that I know of here, so we'll go back to the spine, but nothing, no sign there. And they also had a atrial septal occluder here as well. Okay, so this is just a quick case. We do some pre-procedural CTs for mitral valve repair, robotic mitral valve repair, and
Are you guys seeing an image? I'm not seeing anything.
Yeah, I'm sorry.
Yeah, Brent, unfortunately, I think you have every time you close and reopen the window, you have to select it again.
Can you see it now?
Yeah.
Okay, sorry about that. So this is a pre-procedural CTA for mitral valve surgery, and we're doing a fair amount of these for robotic repair of the mitral valve. And it's just a quick case showing that even, you can tell this is a non-gated CTA, and just a really good demonstration of how even on the non-gated CT, we're looking here at the mitral valve plane, and you can see the reason for this patient's needed mitral valve repair is that you have this pronounced mitral valve prolapse, and just this ballooning, backwards of the mitral valve leaflets of both the anterior and posterior leaflet. And, you can look at how this is related to the mitral valve plane. It only takes just a couple of millimeters. Definition is a couple of millimeters, 3 millimeters, I believe, posterior to the mitral valve plane to actually call mitral valve prolapse. And here you can see this is already 12 millimeters posterior to the mitral valve plane. So, and you can see as we're scanning through this that the mitral valve is actually moving, and this is during systole here that you can see this ballooning backwards. So, a nice case of mitral valve prolapse on a non-gated CT examination. And okay, just another quick case here. Let me switch the Cyrix. Okay, can you see this?
Yep.
Okay, so this is a young, relatively young patient with HIV, and came in with this chest CT in the acute setting. And let me just center this. You can already see that you know, there are multiple cavities here, relatively thick-walled cavities with little connections to the bronchi. You have a lot of tree and bud opacities, some ground glass here, and any day of the week, I think anyone would be really concerned about tuberculosis here. And so it's just, you know, as I tell our residents, I mean, that's the first, second, and third diagnoses here, but then the fourth diagnosis would be something like an atypical mycobacterial infection, like either a MAI, or, as in this case, I didn't realize until I started to do some work with this that we have a fair number of cases now for whatever reason of Mycobacterium kansasii, and this is Mycobacterium kansasii that is causing a you know, so-called classic appearance of the non-tuberculous infection with cavities and tree and bud and distortion that could easily be you know, mistaken for tuberculosis. So, so this is a nice demonstration of Mycobacterium kansasii and cavitary disease. So.
Okay, Brent, thanks.
Yep.
Do
you have time for one more? Or no?
yeah, I was going to say I've seen a few cases of M. kansasii, and it seems to look more like TB than the non-classical pattern of MAC. Because you know, a lot of the literature says it's like the second most common isolate in North America after Mycobacterium avium complex. But you know, we don't see that much of it. But the ones I have seen look more like your case, cavitary stuff that you know, be TB 1, 2, and 3. I don't know, David or Seth or Travis, if you guys have seen a lot of M. kansasii.
Not much.
No, the one question I was going to ask, it's usually in smokers, correct? Do you get this kind of pattern? Or is
yeah, the classical pattern, yeah, it's more associated with older men with COPD.
I saw a couple cases at in Colorado, but I think I've seen one here. So.
No, we have even more cases than I thought, and I'll bring some more in, and we can discuss those. So,
right. And I think there's a high prevalence in some of the miners in South Africa, who are also, many of them have TB too. But if I recall, the gold miners, if I recall correctly, there's a high prevalence there.
Oh, and I just have one last case here. Can you see the case?
We do.
Okay. This is a case of a patient who came in with suspicion of a cardiomyopathy. And just ignore this jet. We debated whether this was, you know, an ASD or whether this was just a draining you know, inflow from the IVC here. But look at the right heart here. You know, we can see that the right heart is enlarged compared to the left. You can see that there's some motion abnormalities as well. You can see along the anterior wall almost this dyskinesis with bulging outward of the anterior wall of the RV. And certainly this is not a you know, a nicely moving segment of the RV. Let's take a look at some other, can't see it as well there. Take a look at some other images here, another 4-chamber stene showing more kind of almost dyskinesis with little almost aneurysms of the RV. Let me show you some of the late enhancement, gadolinium enhancement. So gadolinium enhancement here we thought was positive for portions of the RV, especially along the septum and even out to the regions of the outflow tract. We thought we could see just a little bit of enhancement here. Also, let me show you within the LV, there is a little bit of enhancement of the intralateral wall here. Let me show you a little bit more of that delayed enhancement You can see some delayed enhancement along the RV, along the septum on the RV side. And so, does anybody want to kind of guess what this was? Any votes for anything?
I mean, I wasn't even, it looks, I'm sorry, I was doing something else. What, is it a young patient or older patient?
Yeah, this is a young patient. A lot of enhancement within the RV on the RV side here. And let me show you, Seth, in case you didn't see the sine. But we have these areas of dyskinesis and what looked like little, maybe outpouchings here of the RV. The RV was enlarged. So anybody,
I mean, it looks like ARVC, but I've seen a couple cases of sarcoid do that too. But I think common things being common to be ARVC. But
okay, and that's exactly what I thought. And I thought, oh gosh, this is such a wonderful case of arrhythmogenic right ventricular dysplasia. It has every characteristic that I'd look for, the dyskinesis of the RV, little aneurysms, enhancement on mainly the RV side. So they did an endomyocardial biopsy, and of course this turned out to be sarcoid. So this, and we have seen cases of ARVC involving the LV, so I just chalked this up to a little bit of ARVD in the LV, but most of it seemed to be on the RV side. But of course that's this really was a humbling case, and it looked, the RV was so kind of abnormal here that I was focused on that, and yeah, but this turned out to be sarcoid, slam dunk sarcoid, apparently on path.
yeah, no, I just and I said it could be sarcoid, and we had seen now one in fellowship and one here that looks very similar that turned out to be sarcoid. So
okay, all right, that's all I have here.
All right, thank you, David. Do you have any cases?
I do have two cases here.
All right.
So can people see a chest röntgenogram? Cannot rule out radiograph. Yes, we have visualization, guys.
Yes, we see it.
yeah.
Thank you. Okay, so we have this radial pattern of extra lines in the bases here corresponding to bronchiectasis. Let me show you CT scan from the same era. And this fellow has bronchiectasis in upper parts of the lung, but mostly in lower lobes here, and there's some mucus plugging or infection in these dilated airways as well. If we go back 5 years, here's 2011, and there were a few cystic lesions maybe in the bases, and a little bit of bronchial wall thickening and some dilation, but things have really increased quite a bit in the 5 years to the current state like this. And this fellow was worked up extensively, and his only abnormality is alpha-1 antitrypsin deficiency. So I think somebody showed a case maybe 6 months ago of alpha-1 antitrypsin deficiency as a cause of bronchiectasis in this conference. This is one of the first examples I've seen here of alpha-1 antitrypsin deficiency not presenting with basal emphysema or liver disease, but instead with bronchiectasis. Am I imagining that there was a similar case shown some time ago?
We've talked about it, so probably.
Okay.
And we had a similar case here, yeah. So I presented that case last time, 6 months ago, I think.
Okay, so that was probably the one I was remembering. Let me show you this case. This fellow has CLL. He's an older man in his 70s, and I should not be showing his name here. Let me see if I can make that go away. Okay, and he's got this rather large thing here. Somebody said at the outside that this looks as if he has 2 hearts. That is not the case. This is not a heart. And here it is on CT, this very big mass that seems to be originating from the posterior part of the mediastinum and then extending posteriorly, and it is accompanied by some pleural effusion. So what do you guys think? What are the possibilities here?
Could be a big extranodal lymphoma.
Yeah, it's
Be a
kind of,
big rock.
It's very
kind of
homogeneous and kind of
lymphoma.
pushing everything away, not really causing much mass effect other than the adjacent airway. Did he get a leukemia on top of it? And this is a giant, what do we call it now? Granulocytic
Sarcoma.
Is it a bronchogenic? Is it cystic or is it soft
It's
tissue? Can you?
it's solid. It's not cystic,
And
and it has probably has some calcium in it. I think
Yeah.
I think contrast scan with a little calcium.
And the things that I've seen that are that big, I always think of a ganglioneuroma back there, even though it's, I don't know. That's what I always think when I see something that big sitting back there going along the spine. But those are so uncommon.
The interesting thing is his presenting symptoms. He has a Fitbit, and he said that it was showing some tachycardia for him. So he's a very fit guy, and he thought his heart rate was too his And then, of course, there was a little bit of pleuritic chest pain. So he came to the doc, but his main complaint was his Fitbit was showing his heart rate was in his 60s, and he normally evidently has a slower heart rate than that.
David, did you say he has CLL?
He does.
You know,
Oh, he
I'm
has
guessing,
CLL.
I'm guessing you only show rare stuff, so I would say it's some weird extramedullary hematopoiesis that just happens to be one big mass, something funky.
Well, the resident who go ahead.
I was going to throw out with the tachycardia maybe a paraganglioma.
The tachycardia was 60s. It's relative tachycardia for this very fit guy. So the resident suggested that this was a fibrous tumor of the pleura. I've not seen a fibrous tumor in this location before. It really seems to be originating from the mediastinum. The lesion was biopsied, and the pathologist came back, said that there are these small, fairly uniform cells, and there's a fair mitotic rate, and was going to call it a small cell carcinoma of the lung. But I called him up and said, this thing looks much firmer than the usual small cell, and it's a funny location and a funny shape for that. And I asked him about the resident's consideration of a fibrous tumor. And they did some stains for that, and it stains positive with a marker. I'm not sure what the current immune cytochemistry marker is.
34.
For fibrous tumor of the pleura. What were you saying?
CD34.
There was that, and there was something else. There was a CD, and there was some other thing that they use, and those were strongly positive. And so, the pathologist, after consultation with the radiologist, amazing how often this changes. That this will change the path diagnosis, and this became a fibrous tumor of the pleura. They also ruled out a synovial sarcoma, which is another cause of a big pleural or mediastinal or even chest wall mass. That staining was negative, and they looked for the gene rearrangement that goes with synovial sarcoma. It was not present. So this ends up being a large fibrous tumor with medial origin, and this thing was adherent to everything at operation, and they had to do a pneumonectomy. They tried to stay extrapleural as much as they could in resecting this big thing, but it ended up being a big operation and extrapleural pneumonectomy as a result. The diaphragm was left, so it wasn't the usual extrapleural pneumonectomy that they do for mesothelioma. So a very large fibrous tumor of the pleura with medial origin here, resembling a mediastinal mass.
Any feeding vessel or stalk that you can see?
Thanks, Jeff Caney. Hey, Jerry, how are you?
I don't see that much vessel in the way of it. There was a fair amount of necrosis at pathology too. So, when fibrous tumors get to be this large, you often will see vessels in them. So perhaps this is a vessel and not calcification. Perhaps this is a vessel out here that's enhancing a little bit. I'm not really sure. I'm not really seeing impressive vessels in this thing.
I'm guessing this thing was malignant. I mean, you're saying, because these things obviously can degenerate or have. So it was malignant?
They're considering malignant because of the mitotic rate and so the necrosis within it.
Yeah.
Okay, Jeff, those are the two. Are we still connected?
Can't hear me. Can you hear me now?
Yes.
Okay, let me show you the screen now. You should see a radiograph.
Yep.
Okay, So this guy is from India and was billed as having tuberculosis, which I think we could all believe. And this radiograph was sent to us to, just compare. And I had an old one and it looked the same. The right lung is pretty much destroyed. There's some scarring, volume loss in the upper lobe on the left, and you can see the trach is displaced over. This is a CT from March, which I hope you should still be able to see. And what you'll see, I'll show the lungs first, is there's a lot of bronchiectasis, volume loss in the right lung as we'd expect. The left lung is sort of expanded outwards, a little bit of heterogeneity there. There's a little bit of bronchiectasis posteriorly and at the apex. But what's interesting, and we talked to the pulmonologist about this guy, he's never actually had proven tuberculosis, but he is missing his right pulmonary artery here. So we have an absent pulmonary artery, proximal interruption of the right pulmonary artery. Not a lot of collateral flow like we typically see. I mean, this lung probably doesn't need much blood there. A lot of calcifications, dystrophic. So the question is this the result of TB, or is this a hypoplastic lung that's just kind of maybe got infected at some point, not doing much? I mean, you can see a little bronchial coming here. I don't have an answer. I was curious what you guys thought, but I thought it was kind of an interesting finding. Or because he doesn't have a normal pulmonary artery, was this lung more prone to not fighting off the TB, not clearing as appropriately as one would suspect? The stuff on the left is a little bothersome, that there's some inflammation going on there. But without any cultures or sputum or anything like that, I'm struggling trying to just write this all off as one or the other. But I don't know. What do you guys think?
All right, Jeff, I missed it for a second. Does he have a right pulmonary artery?
Oh, it's a congenitally absent, proximal interruption. You can, let me show you here the P.
Okay.
Yeah, you see it coming out there. It's not even a nubbin, there's no fibrinolysis, there's no stricture. It's just not there.
What about the bronchus now? Is there a right lung? Is there a bronchus going out to those ectatic peripheral bronchi?
Yeah, there's normal airway there, and there is bronchiectasis. This is all bronchiectasis down here.
Mm-hmm.
So I guess the question is, I mean, in the absence, say we didn't have this TB history, have you guys? I mean, we've seen hypoplastic lungs. I've seen them sort of have these transpleural collatus, but I've never seen them shrink down to nothing and have severe bronchiectasis just from underdevelopment. My theory is this thing got infected either with TB or something else, and because of the diminished blood supply and the relatively non-functioning lung, just never really recovered well and kind of shrunk down to nothing. He sort of did an autopneumonectomy.
Yeah, I like that theory. Just that he's subject to recurrent infection with the interruption of the pulmonary artery.
And I think, Jeff, the fact that his right bronchus has almost normal caliber there. So this happened sometime. This is not all congenital small in that right lung. I think it's acquired smallness after he had grown big enough to have an almost normal right bronchial size.
Yeah, it looks actually.
The idea of infection that finished off this lung, and the infection we're seeing it on the other side as well.
Okay.
So probably two things: TB on top of a congenital anomaly and inability to fight infection is a good idea.
Well, it follows my rule of twos then. Okay. Well, here's a companion case to Travis's. Let me pull it up here and show you. This is a patient who presented with chest pain. And you should be able to see a chest CT here. And you can see, did I show this case already? I can't even remember. I don't think I did. There's pulmonary emboli, and there looks like an infarct and some hemorrhage. But what was picked up was this filling defect in the right atrium. And if I make a coronal, I think it's more convincing that it's not just flow, but a true mass. Kind of has these fronds on it. So, the question and it looks a lot like you might see a myxoma with the fronds. They did a cardiac MR, and we had similar issues. I'll see if I can show it. Of seeing the mass. Let's see if I can show it here. I'll roll down a little bit. Let's go down. You can sort of vaguely see it here on the SSFP, and I'll play the same. But right there, you can see it kind of go through the tricuspid valve. I'll come to this right here. So you see right in there that kind of filling defect going right through the tricuspid valve. Let's see if we see it on the perfusion images. Here we go. So there you see it on the perfusion images. As the blood pool fills, there's the filling defect in that right atrium. You can see all the fronds coming off of it. Not the best. This wasn't, unfortunately, the best cardiac MR. And then right there, you can see it herniating through the valve. So this is another myxoma, but this one was on the right. And so the question is, these things do embolize. How much of this is bland thrombus, and how much of this was myxoid tissue that causing this severe inflammatory reaction? Because if you look at what looks like infarct, there's actually vessels running through this. So that kind of goes against these being infarct and maybe more areas of hemorrhage related to this. So I suspect it's a little bit of both, and we're seeing the macroscopic thrombi that were originating off the tumor, and then we're seeing the effects more likely of some of the myxoid tissue causing this sort of vascular insult and some hemorrhage in the right lower lobe. But that was a nice companion case to the other myxoma just because it's on the right, but this one's embolizing to the other side here.
That's impressive. Yeah, you can't blame that one on slice thickness and gaps.
I thought it was a nice pickup on the CT by one of my colleagues. I thought that was pretty impressive too, because it's so easy to get focused on the PE and all the hemorrhage going on here, and we see that flow artifact all the time. But I thought the coronals in this case really, sagittals, really is much more convincing for a mass. Okay, so that was one I did not show. Let me show two cases that were sent to me from the folks in Augusta, Georgia. This was a patient who presented with altered mental status, nausea and vomiting, COPD, or had head neck cancer and hypertension. And I'll show the first radiograph here. Yep. Hold on just a second, guys. All right, sorry about that. I had a quick question here. Let's see. You should see a chest radiograph. So he presented and had this collapse of the left lung, and you can see the right lung is sort of filling in a little bit over here. And so if I go back to the story here, which didn't, there it comes up, and I guess I have to do this so you can see it. Found to have complete left lung collapse, and so they did. I had a CT, which I don't have, showed a pleural effusion and obstructing lesion in the airway. So at this point, they decided to do a thoracentesis. So the next image is right here. And this was kind of interesting. So you see there's actually a pneumothorax on the right. So they went on through a left axillary approach to drain this effusion. And you can see this was done in the ICU. And you have a large pneumothorax on the contralateral side, and where there's displacement of the diaphragm, and it looks like a tension pneumothorax. So presumably what happened when they went in this side, they hit some of the right lung, which had herniated across to fill up for the collapsed lung, and gave them a contralateral pneumothorax. And then they had to put pigtails in both sides. So here they've reduced that pneumothorax. And you can see the drainage, but the left lung still collapsed. There's still some herniation of the lung over. So a contralateral pneumothorax following thoracentesis. I have not seen that before, but I thought that was kind of fun. And the other case they sent me, it's a pretty classic example. I'll just show it quickly. Assuming it'll open up. There we go. So this is a patient who gets intermittent gastric outlet obstruction, and I'm going to show you a coronal CT. But just a classic example of a intrathoracic stomach with an organoaxial volvulus. I know Howard has shown some cases we talked. So it's flipped upside down so the greater curvature is along the top. And we see there's actually colon in here because the stomach brings in the transverse mesocolon. So this patient intermittently obstructs. We don't have an image of the obstruction, but because it is not a surgical candidate, so they just have to treat it conservatively. But that is one of the complications. So when you have this organoaxial volvulus, it doesn't obstruct, but then it twists around the vertical axis, so then you get a mesenteroaxial volvulus, and you can get almost like a pretzel-shaped stomach and get a gastric outlet obstruction from that. And that usually requires surgical intervention. Okay, so those are the two cases from Augusta. I'm just going to show one more case. This was a consult to me. This is an older man. He's in his 80s. He's presenting acutely short of breath, and here is his radiograph from back in December. You can see he has a cardiac pacer in, not much going on. his presentation. Here's his radiographic presentation. So now we're in August. He's got patchy lung consolidation. You may question a little bit of edema, but it's a little bit more confluent. Don't see much in the way of effusions. And his CT, I think, tells all. Put the coronal up first. You might pick up the diagnosis. So you see we've got this crazy paving. We've got perilobular consolidation. Both lungs, some areas more confluent than others. And on the soft tissue windows, you'll notice how dense the liver is, how dense the lung parenchyma is. This is one of the more extensive cases of amiodarone toxicity I've seen with the dense consolidation. He's been on amio for about 2 years. Apparently, they did a surgical biopsy, and we're seeing organizing pneumonia and foamy macrophages, which is one of the findings of it. And of course, it's hard to treat because the amio hangs around for a long time, or it's metabolite. But I've been reading a little bit about this. I've had a few cases recently, and they make the distinction between amiodarone effect, which is the accumulation of phospholipids, sometimes some deposition, and amiodarone toxicity, where you get a true immunologic response like organizing pneumonia, alveolar damage. So I think here we sort of have a mixed picture. This to me looks like acute organizing pneumonia, maybe some DAD mixed in there. Whereas the deposition is often, and the dense liver is often a sign of just the effect of it. So he presented with an acute illness, which fits with the toxicity. So
Was this thyroid dense too, Jeff?
that's a good question. Let's see. Find a thyroid. Yeah, it's pretty dense up there.
Yeah.
So yeah, good amio case. All right. Well, it's 3 o'clock. Thanks everybody, and we'll resume next week.
Thanks.
All right. Bye-bye.